Next on our agenda today is the symposium on nutrition for preterm babies, lessons learned from cow's milk derived fortifiers. And I'm pleased to introduce Dr. Boris W. Kramer. Dr. Boris' research interests are common on microbe in NEC and BPD, a stem cell therapy, development of lung, brain, and immune system after preterm birth. He has supervised over 25 completed PhDs and has over 325 peer-reviewed papers in international journals and 70 reviews in textbooks. He is an associate editor of the Pediatric Research and Neonatology. He is a junior member of the medical faculty of Wasberg in 2006 and currently practices his profession in Maastricht, Netherlands, as a neonatologist and a leader of experimental research group. He holds a part-time position at the Institute of Women's Health at the University of College in London. He has also received several national and international awards, such as the Young Scientist of ESPR, the Dutch Society of Pediatrics, and was chosen as a top talent by the Faculty of Medicine in 2008. What an extensive profile you've got there, Dr. Boris. I think it will take a whole day to enumerate all of them. For now, I would also encourage our attendees to send their queries and doubts to Dr. Boris. Without any further ado, I welcome Dr. Boris for his symposium. Good afternoon, Doctor. The air is yours.
Afternoon. Thank you very much for the kind introduction. Yes, if you get old, the list of positions increase. Thank you very much for the opportunity to discuss the lessons that we have learned from cow's milk derived fortifiers. And I want to discuss with you what are the benefits and the clinical evidence around cow's milk fortifiers versus human milk fortifiers, and discuss with you the fact that the safety of cow's milk derived fortifier was never prospectively tested. And that this is an inherent challenge with every innovation that we introduce without proper testing, so that we need really to verify the overall effects in the long run. Now, eat responsibly. We just had lunch. Save room for dessert. So I want to focus your attention on the overall aim of our nutritional regime. We want to allow babies that have such a premature start like Leonie to grow almost better than in utero. And why is this growth so important? If there is not an appropriate growth rate, all outcomes will be poor. So you can just predict how the outcome is by looking at the growth chart, and information that usually is the beginning of every clinical round. So we have to pay attention to growth. Why is this so important? Here you get an idea about the exponential development of the brain. And between 25 and 40 weeks, the brain mass increases every 48 hours. 250,000 neurons are formed per minute. And per second, you have 1.8 million synapses. You see the different species over here. This is human development. This is development in monkey. So around term birth, you have this exponential growth of the brain at its maximum. So a preterm baby is just sitting here in the increasing growth. To give you an idea about these 120 to 130 kilocalories per kilogram a day, I put this into perspective. Today, the new round and course of the Tour de France is being published. And if you perform among the top athletes in the world, you will use 100 kilocalories per kilogram per day. A preterm baby in our NICU needs 120 to 130 kilocalories per kilogram. So not even the most challenging physical activity in our adulthood comes close to the caloric need of a baby. So if you keep this in mind, you are not surprised by those findings. Schneider and colleagues published in 2018 a paper that has measured these effects in the first 2 weeks of life on brain growth. And it became clear that the enteral nutrient intake determines this drive toward brain development. And here you have an idea, the cerebral volume given here on the y-axis. And here is the calories given in total, and here the proteins given in total. And you clearly see the linear relationship between brain growth and overall calories can be pinned down to the protein. Or to put it in other terms, if you don't have protein as the gold current metabolism, your growth will be futile. Now, what did it show? It was not only the volume of the brain, but even the psychomotor outcome after 18 months. So if a baby does not grow, all outcomes will be poor, and that can be even predicted in the first life. Now, how do we tackle this to give the best helping hand to our preterm baby? You want to make sure that you optimize enteral nutrition without increasing the risk of neck. That is the essence of all our ideas. So just pouring in calories and by that increasing the risk of neck is not the way to go. So what are then the appropriate calories to pour in? Well, here you have neck or death on the y-axis, shown as survival. And here you have the different amounts of human milk, from 100 milligrams per kilogram per day to no human milk. And you can clearly see a dose response. The more human milk the babies get, the higher is the chance of survival. So it is pretty clear that this is an appropriate source of enteral nutrition. So we can meticulously calculate the calories that we give with human breast milk. But are we really sure that we are calculating this correctly? Well, you have to pay attention to facts like pasteurizing and freezing. If you are using donor milk from any source, that is very different to the milk that a mother who has just been given birth to a preterm baby. And a preterm infant needs not only additional protein as the gold standard of metabolism, but also calcium and phosphorus for bone growth. So we have to think further about breast milk. The gestation at birth plays a role for the caloric content. The duration of lactation plays a role. The longer a mother has been lactating, the lower the caloric content is. The nutrition of the mother plays a role, and you have even variations during the time of the day in the caloric content of the breast. So, putting all this together, the majority of neonatologists is convinced that you need fortifiers in order to literally beef up the milk that the mother can express. And we know two sources of those fortifiers. One is of cow's milk origin or bovine origin versus human origin. I will just compare those two and also discuss briefly with you the question when to start giving fortifiers. Now, if we go to a practical example of our Leonie, 26 plus 5 weeks and now 660 grams, and she gets mother's own milk. And if we look at the recommendation for fortification, the majority of the protein in her nutrition will be of bovine origin, not of human origin. So that gives you an idea about the magnitude of the problem and the need to give sufficient protein. So in this situation, already the majority of the protein will be of bovine origin. Now, how did the cow's milk got introduced into neonatology, especially in preterm care? Well, it was need. If you don't have a fortifier derived from human breast milk, you take the cow's milk derived fortifier that is easily made, easily produced, and you have abundance of the cow's milk as a starting product. And we know that the earlier we give cow's milk derived fortifier to preterm babies, the higher is the risk for necrotizing enterocolitis. So the time point in life when this cow's milk derived protein is being introduced represents a risk factor for NEC. So if you talk to your colleagues, you will find units that will wait for a full enteral feed before they introduce their cow's milk derived fortifier. They are very much aware of the risk that earlier introduction will increase the risk of NEC. So you can ask now the other way around. If it is not sure when it is safe to introduce cow's milk derived fortifiers, when is it safe to introduce any? So is there a minimal safe concentration that you can introduce? The answer is no. You have a yes or no situation. You cannot use lower concentrations or amounts of cow's milk to actually use in that. And since it was introduced by need, it was rarely studied prospectively. And especially if you go to the literature, this clear-cut distinction between a complete exclusive human milk diet and a cow's milk beefed up human milk nutrition was not consistently done. So you can find literature where a human milk diet is being described. If you go into the material and method, it turns out that it is mother's own milk plus cow's milk derived fortifier, which is not the idea of an exclusively human milk diet. Now, there is a very remarkable Cochrane analysis out which only analyzes one clinical trial, and that was the optimal trial, which needed a corrigendum. However, this Cochrane review was already published before that corrigendum was published. Now, what is the optimal? They wanted to know in a strictly human milk diet where they had human milk derived fortifiers plus mother's own milk or donor milk versus bovine derived fortifier with the same basis of mother's own milk or donor milk. So this is a true comparison between an exclusively human milk diet and a cow's milk derived fortifier in human milk. And they wanted, as primary outcome, they wanted to know whether this affects feeding intolerance. And they defined feeding interruption for more than 12 hours or 50% reduction in feeding volume as a feeding intolerance. Now, here is the data on the feeding tolerance. And to make a long story short, they failed their primary outcome. However, they found a significant reduction in retinopathy of prematurity in the exclusive human milk. Well, retinopathy is a very interesting outcome. We underestimate the importance of retinopathy, but it is a biomarker for neurodevelopment. If you have problems with the microvasculature, which can be visualized on the retina, there are also problems in the brain and elsewhere. And it has been known for some time that any amount of human milk intake is strongly associated with a protection against ROP and severe ROP. So this optimum trial was adding to the body of knowledge that human milk plays a role in the prevention of retinopathy of prematurity. And it added the aspect that the use of human milk diet can be even more protective than human milk plus cow's milk derived fortifier. However, this was not the only study that was consistently distinguishing between human milk fortifiers in human milk and cow's milk derived fortifier in human. And this is a meta analysis which looked at two of those studies, the optimum trial and the previous study relevant, and looking at the risk for NEC in these babies. Here we are looking now at 200 and 130 babies in total. And they showed a significant reduction in the risk of NEC, favoring the human milk derived fortifier. Now, is this the only available data where a consistent distinction between an exclusive human milk diet and cow's milk derived fortification was done? With a reanalysis of such trial, we could now identify a third source of clinical data. And if we put this now all together, we are looking at 220 infants that got cow's milk derived fortifier versus 233 infants that got human milk derived. So now we are looking at a meta-analysis of more than 200 babies in each arm. And they confirm that NEC is significantly reduced with the use of exclusive human milk diet. They confirm that ROP is reduced significantly in a human milk trial. However, the effect on bronchopulmonary dysplasia is not reaching significance, neither is the effect on death. And what about late onset sepsis? It has not changed. However, if you define feeding intolerance as no enteral feeds for more than 24 hours, this could be extracted from two studies. It is highly significantly different. Now, where are we with the future and ongoing clinical trials? There is a trial ongoing in Sweden that will have 222 babies in both arms, and they will compare a human milk-based derived fortifier versus bovine fortifier from 100 milliliters per kilogram per day enteral intake of mother's own milk. And they will have a primary outcome focusing on NEC, sepsis, and mortality. Well, the incidence of NEC in Sweden is pretty low. And even if you have significant changes, it will not change major outcome meta-analysis. You will add 100 less data. So we are very eagerly waiting for data whether this effect can be also seen in Sweden, which is an extremely breastfeeding friendly country and where the conditions for donor milk are also very favorable. Now, getting back to the initial studies. So if we don't have an effect on death in BPD, what other effects do we have? For example, on the ventilation days. However, it was not strong enough to have an effect on BPD as such. Well, and what about this development of the babies? Well, the earlier we can fortify, the more enteral calories we can provide for the baby and for the growth. And this has been done in prospective studies. For example, they tested using human milk-derived fortifiers late with more than 60 milliliters of enteral feeds per day versus early, even before reaching 60 milliliters per kilogram per day. And what was shown, it was first of all safe, but interestingly, it resulted in a decrease of BPD. So that is remarkable, since you can introduce human milk-derived fortifiers even very early in the postnatal life after preterm birth. I have not met any neonatologist who would dare to introduce a cow's milk derived fortifier that early in nutrition. The earliest that I know are 80 to 100 milliliters per kilogram per day. Now, does this affect growth? Yes, it does affect. And this is a study that looked in a single center how the growth rate was in preterm babies when started at 60 milliliters per kilogram per day. And they found an appropriate growth rate. And they have published their feeding guidelines, which I will show you shortly. Now, what about other studies that had this stringent approach between human milk derived and cow's milk derived? If they looked at weight and length, they did not find a significant difference. However, they found a significant difference in the growth rate of the head circumference, which was considered as a surrogate for brain development. So this effect needs to be confirmed in future studies, and the ongoing Swedish trial will be very interesting to record this outcome. So the growth can be affected by the introduction of human milk fortifiers. Now, how do they do this at Baylor College in Texas, where this study has been done? So they start in the first 4 days with 20 to 40 milliliters of enteral feeding. And they supplement it with total parenteral nutrition, and they start lipids on the first day of life. So they get in total 120 milliliters per kilogram on the first day, and they increase it to 150 milliliters from the third day onwards. And on day 5, they already add a human milk-derived fortifier in order to beef up the caloric intake, which also allows them to reduce the intake of parenteral nutrition. So that is a very stringent protocol how to increase enteral feeds, and it is safe to increase the enteral feeds with 20 milliliters per kilogram per day. However, it also takes discipline to really look into this and to see that this is actually working in your unit and can be applied in your unit. Now, when do you start enteral feeding per se? Well, our aim is to give colostrum within the first 6 hours of birth. And to put it this way, there is no good evidence to withhold feed in the majority of the babies unless you have congenital disorder. Encourage the mother to express colostrum immediately after birth and do this repetitively. If you have less than a milliliter, place it into the cheek or mouth. If you have more than 1 milliliter, give it via the nasogastric tube. Why do we distinguish? Well, you will have losses in the nasogastric tube. And if most of the colostrum is being left in the nasogastric tube, well, then you are not getting it to the place where it needs to be. It is liquid gold, and it is unique. There is a unique situation in the lactating tissue where the tight junctions are still open. And that is a transient situation which will go away shortly. And this allows the unique composition of colostrum. And it already conveys a microbiome to the baby. And there is one thing that we have to pay attention to. Cow's milk has almost no oligosaccharides. And human milk is very rich in oligosaccharides. And we are just starting to appreciate and understand the importance of oligosaccharides. They are extremely helpful in establishing a microbiome. So if you give a microbiome, a mother's own raw breast milk, and if you supplement it with a human milk-derived fortifier, you are increasing the oligosaccharides, something that any cow's milk-derived fortifier cannot do. And is this clinically important? Yes. Here you see the protective effect of raw milk versus pasteurized milk. So if you pasteurize mother's own milk, the protective factor against BPD is lost. These two trials have been identified by our work when we wanted to study the role of mother's own milk and donor milk for the development of BPD. But this is an example how pasteurizing can do away with the protective effect. And you are killing, namely, the microbiome that is inherent in mother's raw breast milk. And what does the use of antibiotics means for the microbiome? Well, if you don't give any antibiotics, this is the development within 6 weeks in the gut of a newborn baby. If you give antibiotics for 2 days, it takes 6 weeks to recover from those changes. If you give it for 7 days, it is not enough to recover within 6 weeks. So that is the reason why we strongly ensure that antibiotics are only prescribed for 48 hours, and that there is a review after 48 hours whether it is necessary to continue to give antibiotics or whether it is okay to stop them, since it has such a long period of time on the recovery of the microbiome. And we know since a long period of time and throughout the world, this is data from Brazil, for example, that the diversity of the microbiome plays a role in the development of NEC. So how can we do something about the diversity? And the answer is human milk oligosaccharides. So the lower the diversity of human milk oligosaccharides, the lower is the microbiome diversity, the higher the risk for NEC. And that points to a new field of research where we have to ask questions how the composition of breast milk, both with the microbiome, but also with the human milk oligosaccharides, plays a role in establishing a microbiome that is protecting the baby against NEC or other gut-associated diseases like late onset syndrome. This cartoon is borrowed from adult medicine, and they are pointing to a microbiome-directed intervention. Well, if you look what we are already doing, we are already giving individualized nutrition. We have different supplements at hand that can have an effect on the micro composition and function. So we have to be aware that our clinical care has effects on the microbiome, that changes in the microbiome are associated with adverse outcomes, and that we have to consider whether we can establish a microbiome-driven care for our preterm babies. And the Japanese Society for Pediatrics has jumped ahead last year. They are pointing out that they want an exclusively breast milk nutrition for preterm babies. The exclusive human milk diet should be established in using only breast milk and human milk derived fortifiers. And if donor milk is not available, then the solution of the United Arab Emirates is a very interesting one, that you ask related family members to donate milk. So, ladies and gentlemen, let me summarize. This is the outcome of Leonie, who started as a preterm baby and now has grown into a very nice young lady. Her mother was breastfeeding and dedicated her life to this preterm baby. And so the outcome has been very, very good. Can we improve that for the next generation of preterm babies? Well, fortification works. There is no doubt about that. When to start? That is really a tricky question. If you compare human milk derived versus cow's milk derived fortifier, it is clear, if you consider all clinical data that is available, that NEC is lower with human milk derived fortifiers, that ROP is lower, and that you can start earlier and thus give more calories with will be very interesting to see the long-term data, whether this also correlates into better neurodevelopmental outcomes at later life. Thank you very much for your attention. And I want to thank my collaborators, and I'm looking forward to your questions. Thank you very much.
We have a lot of debates going on here about the product, and many times it is happening that we don't have the breast milk, or if we have the breast milk, that we don't have the human milk modifier. So, as you suggest that lower NEC, lower ROP, but still the debate on the financial thing. Do you think the financially it is viable? What do you think? Do you have any recent data, or not the company data?
The cost analysis is always a national one.
Mhm.
The cost that I have to pay for treatment of ROP or NEC or other adverse outcomes is not comparable to the cost that you have. So
Okay.
if you want to address that question in the right manner, I'm afraid you have to do this country
Sure.
by country, and then you will find all of a sudden that, for example, using caffeine is one of the most cost-effective aspects. Why? It keeps your cardiac surgeon away from the PDA ligation, and so that needs to be done for each country separately. The cost varies so much.
Okay, so that's it, Dr. Boris. Thanks so very much. It's a very enlightening, and you put it very nicely. We will get those article and the reference which you gave it in the last your talk, and then we will be in touch with you if we have more questions about that. But just for the timing, I have to conclude, and we'll see you soon.
Thank you very much. I wish you a good proceeding of your conference, and congratulations on the program.
Thank you, Dr.